All right, welcome to The Explainer. Today we're going to piece together a really complex medical puzzle. It's a condition that kind of borrows its identity from several others, which creates a very unique and, honestly, a challenging picture for doctors.
Okay, let's just dive right in. Imagine a patient shows up with this exact list of symptoms. You hear joint pain, and your mind might immediately go to something like rheumatoid arthritis, right? Then you see the puffy hands, and those fingers that change color in the cold. That's a classic sign called Raynaud phenomenon. And you start thinking, maybe this is scleroderma. But what if it doesn't quite fit either one perfectly? What's the thread tying all these clues together?
And that's really the heart of the matter, isn't it? In medicine, we love diagnoses that fit into neat little boxes. But the human body doesn't always play by the rules. When a patient's symptoms start to overlap and blur the lines between known diseases, doctors have to think outside the box.
So, this brings us to the first piece of our puzzle. What exactly do we mean when we call something an overlap condition?
Well, here it is. Mixed connective tissue disease, or MCTD for short. It's an autoimmune disorder, which basically means the body's own immune system gets confused and starts attacking its own healthy tissues. And that word mixed is the most important part. Think of it like a mosaic, combining features you'd normally see in three completely separate conditions: lupus, scleroderma, and an inflammatory muscle disease called polymyositis.
And this chart really shows you what we're talking about. Just look at that MCTD column. It's like it goes shopping for symptoms. It can grab the classic butterfly rash from lupus. It almost always has the Raynaud phenomenon and puffy fingers that you see in scleroderma. And, really importantly, it can also develop the serious lung scarring or fibrosis that's a major concern in scleroderma. It's this unique blend that makes it so tough to identify at first.
So if the symptoms are such a mix and match, how in the world do you solve this puzzle? Well, it turns out you have to look for a very specific defining clue that's hidden in the patient's blood.
But first, a super quick primer. In autoimmune diseases, the immune system makes these things called autoantibodies. The easiest way to think of them is like friendly fire. They're antibody proteins that are supposed to fight off invaders like viruses, but they get confused and start targeting the body's own healthy cells instead.
And this is the smoking gun. The serologic hallmark, which is just a fancy way of saying the definitive sign found in the blood, for MCTD is a very specific autoantibody called anti-U1RNP. Now, other diseases can have this antibody, but the key for MCTD is that it's present in very high amounts, or what doctors call high titers. Finding these high levels is that aha moment when a doctor can finally solve the puzzle and say with confidence, this is mixed connective tissue disease.
Okay, so we found our key clue. Now let's break down the different pieces of this mosaic. What does this mix of features actually look and feel like for a patient? Let's start with the things that look like lupus. You see some of the classics here: that butterfly rash across the face, arthritis, and inflammation around the lining of the heart and lungs. But here's a really important distinction. While people with MCTD can get kidney disease, it's usually much less severe than what you might see in someone with full-blown lupus. And that's a critical piece of the puzzle for a patient's long-term outlook. Now let's switch gears to the scleroderma side of things. Like we said, Raynaud phenomenon is pretty much a given here. It's one of the most consistent symptoms across the board. You'll also see those puffy, swollen fingers, which is often one of the first signs. And it can affect things internally too. For instance, many patients get something called esophageal dysmotility, which just means the muscles in their esophagus weaken, making it hard to swallow food. And finally, we have to talk about the muscles and joints. The arthritis in MCTD can be surprisingly aggressive. Sometimes it can even cause damage to the joints, what we call erosions, that looks a lot like rheumatoid arthritis. The disease also borrows from polymyositis, causing muscle inflammation. And for a patient, this feels like a deep weakness in the muscles closest to the center of the body, making it tough to do simple things like comb your hair or lift your arms. In blood tests, doctors see this damage as elevated muscle enzymes. So MCTD clearly affects many parts of the body, but there is one organ system that demands the most careful attention. Because, frankly, it poses the greatest threat. We're talking about the lungs. Take a look at this number, 66%. What do you think that represents? Well, that's the risk. Up to 2/3 of all patients with MCTD will develop what's called interstitial lung disease, or ILD. This is a really serious condition where inflammation leads to scarring or fibrosis of the lung tissue itself. That scarring makes the lungs stiff and makes it much, much harder to breathe. And if you take away only one thing from this section, please let it be this. Even beyond ILD, a related condition called pulmonary arterial hypertension, or PAH, is the #1 cause of death in people with MCTD. It's essentially high blood pressure specifically in the arteries of your lungs. This puts a huge strain on the right side of the heart, and over time, it can lead to heart failure. So because this risk is so incredibly serious, being proactive is everything. You absolutely cannot wait for symptoms to show up. The guidelines are clear. When someone is first diagnosed, they should get baseline breathing tests and a high-resolution CT scan of their chest. Then, every single year, they need to repeat those breathing tests and get an echocardiogram to check for any early signs of PAH. Catching it early can make all the difference.
Okay, so with such a complicated disease, what does treatment even look like? How do you manage a mosaic? Well, the approach is actually pretty elegant. You treat the pieces.
This table lays it out perfectly. The core principle is that you treat the active feature, not the overall diagnosis. So let's say a patient's main problem is arthritis. Doctors will pull from the rheumatoid arthritis playbook and use medicines like hydroxychloroquine. If muscle inflammation is the big issue, they'll turn to steroids and other immunosuppressants. And for that very serious lung disease we just talked about, that's when they bring out the heavy hitters, like mycophenolate. It's a really targeted approach.
And this is the bottom line. There is no single MCTD drug. The treatment is completely personalized. It's a dynamic strategy that focuses on whatever part of the mix is causing a problem for that patient at that specific moment in time.
Okay, let's wrap this up. After piecing all of this together, what are the most important things you need to remember about this very complex disease?
So to recap the big picture, we've learned that MCTD is a true overlap syndrome, a medical mosaic. The diagnosis really hinges on finding that one key antibody, anti-U1RNP, in the blood. Of all its different features, the lung complications, ILD and PAH, are, without a doubt, the most serious threat. Because it's so complex, treatment isn't one size fits all. It's all about managing whatever symptom is currently active. And that means consistent, regular monitoring isn't just a good idea. It's absolutely essential for staying healthy long-term.
And that leaves us with one last thing to think about. A condition like MCTD isn't just some rare disease. It's actually a fascinating window into how our immune system works. It shows us that the lines we draw between different autoimmune diseases can be pretty blurry, which suggests they might all share some deeper, fundamental connection. It's a powerful reminder that in the incredibly complex world of our own bodies, sometimes the most important lessons come not from the things that fit neatly in a box, but from the fascinating, complicated spaces in between.